Good afternoon, everyone. Today we are going to discuss neonatal jaundice approach and management. So, neonatal jaundice is the most common problem in neonatal intensive care and the newborn period. It is prevalent in up to 60 to 80% of the newborn in all over the world and different geographic worlds. So today outlook of a topic will be the definition, prevalence of the neonatal jaundice, pathophysiology of bilirubin metabolism, what are the risk factors or causes of the hyperbilirubinemia, what are the complications of the hyperbilirubinemia, and let us look at the management part as well. So neonatal jaundice or hyperbilirubinemia is the manifestation of underlying elevated bilirubin more than 95% for the age. Okay. It manifests as yellowish discoloration of the skin or mucous membranes and sclera. So the word jaundice derived from the French word jaune, which means yellow, and icterus is which is yellowish discoloration of the sclera. Okay, it is derived from the Greek word icterus, which means yellow. So it is manifestation of the many extrahepatic, hepatic, and hemolytic causes. However, in this today we are discussing in the majority causes of the extrahepatic causes and hemolytic causes. Okay. So in newborn period, because we encounter most of the causes are the extrahepatic causes. So let's come to the prevalence. Approximately 60% to 80% of the babies all over the world. It is more common in preterm, approximately 80%. When compared to the term, it is more in preterm babies. It is the most common cause of readmission after birth and discharge. So one of the most prevalent problem that everyone should be thorough with the problem. So let us look at the pathophysiology of the bilirubin. Okay. So bilirubin, we know, is the catabolism or end products of the catabolism of the heme protein. So overall, we can look at the picture here. So most of the bilirubin is produced from the reticuloendothelial system, and the few up to 20% from the non-heme proteins as well. From after the formation of bilirubin in the reticuloendothelial system, it gets transported to the liver with the help of albumin. In the liver, it undergoes conjugation and gets excreted into the bile. Okay, and from the bile, it undergoes further transformation to be excreted in the stool or to be excreted in the urine, and some of them it can also be reabsorbed with the help of the enterohepatic circulation. So this is the overall picture. You can see reticuloendothelial system, formation of bilirubin here. 80% is from the hemoglobin, 20% from the other hemoproteins. So it is bilirubin is unconjugated bilirubin is not water soluble. It has to be bound to the bilirubin albumin to be transported in the serum. From there, it gets transported into the hepatocytes with the help of organic anion polypeptides and other peptides transporters. Once it enters the liver, it undergoes binding and conjugation subsequently. Let's see the next steps in the subsequent. Here you can see the bilirubin production. Most of them from the catabolism of the old RBCs in the reticuloendothelial system, and few of them can be the non-heme proteins from the ineffective erythropoiesis and other heme proteins in the liver. Okay. So the heme, with the help of heme oxygenase, gets transformed into the biliverdin, and this heme oxygenase is the rate limiting step in the formation of the bilirubin. So this is important to know, because in further we can see the medication which can block. However, now we have definitely therapies and not available, but you can see the therapies as well. So after bilirubin formation, the reticuloendothelial system, it has to be transported to the liver through the serum. Okay, it's bound to the albumin. So this is very important again. Okay, so predominantly the unconjugated bilirubin is transported with bound to the albumin. When there is hypoalbuminemia, then unbound bilirubin will be high, which can cross the blood-brain barrier and which can lead to the consequences of the hyperbilirubinemia, which is the significant risk factor. So albumin bound bilirubin get transported to the hepatocytes with the help of organic anion transport proteins or polypeptides. Once it enters hepatocyte, it binds to the ligand in the cytoplasm. Then it undergoes glucuronidation. Okay, with the help of the UDP glucuronide transferase 1A1 gene. Okay. So mutation of the gene and loss of function of the gene can lead to the hyperbilirubinemia. We are not focusing predominantly on this, but this is the importance of knowing the pathophysiology. Okay. From the smooth endoplasmic reticulum, it's transported into the transport vesicles and excreted into the biliary canaliculi with the help of MRP2, multi-drug associated protein. Mutation of this lead to the Tubin-Johnson syndrome. So once it enters the hepatic canaliculi, okay. So we have seen here that is ligandin, it undergoes glucuronidation, then excreted into the canaliculi. From canaliculates, it enters the intestine here, okay. So after the canaliculi, it enters the bile ductules, from there into the hepatic duct, 60 duct, and gets entered into the secreted into the intestine. In the intestines, the bilirubin undergo serial transformation with the help of intestinal bacteria. Okay, from here the most of the bilirubin undergo irreversible irreversible products, so which are excreted into the feces, and some of them are water soluble, are reabsorbed and excreted into the urine. So in some of the bilirubin get reabsorbed with the help of enterohepatic circulation. So here the important thing is bilirubin undergoes serial modification in the intestinal lumen with the help of intestinal microbiota. So this is very important. In neonates with decreased establishment of the intestinal microbiota can lead to decreased formation of the end products, which leads to the reabsorb into the enterohepatic circulation and can lead to the increased bilirubin levels in the neonates. The intestinal beta glucuronidase can be expressed by the human intestines as well as by the intestinal microbiota. So here is the one chart which shows the different products measured in the serum, bile, and stool of bilirubin metabolism. Okay. So here you can see in the serum. So the first one is the adult, and next in the neonates. Okay. When it's to the serum, you can see the predominantly bilirubin, unconjugated bilirubin here. Okay, this is unconjugated bilirubin. It is the concentration is higher in the neonates when compared to the adults. When it's come to the bile, so after secretion into the biliary canal bile. So when you look at the bile, the bilirubin diglucuronides and bilirubin monoglucuronides are predominantly seen. When it's come to the neonate, I can say it is bilirubin di and monoglucuronides are present predominantly, along with some that bilirubin as well. When it's come to the stool, this is very important here. See, when it's come to the C, so there is no glucuronides. So mono and diglucuronides are absent in the stool in the adults. When it's come to the neonates, it still persists. So the bilirubin digluconides or monogluconides are still persist in the stool, which these are easily reabsorbed into the enterohepatic circulation and which leads to the elevated bilirubin in the neonates. This is one of the risk factor which lead to the physiological jaundice in neonates. The others are the immaturity of the liver and enzymes, which lead to the decreased conjugation and increased bilirubin levels in the neonates. So here we can look at the enterohepatic circulation. So this is overall the bile synthesis and secretion, but we know the bilirubin one of the constituents of the bile. Okay, so bilirubin follows the bile pathway and it gets excreted into the intestines. When there is bilirubin monogluconides, digluconides are present unmodified in the intestines, they can be reabsorbed along with the bile into the enterohepatic circulation. So here in neonates, because of the decreased intestinal microbiota, so one factor is there is a decrease, immaturity of the liver enzymes, which leads to the decreased conjugation. The other factor is the decreased intestinal microbiota, where can be the presence of bilirubin di and monogluconides, which can be easily reabsorbed into the enterohepatic circulation. So these factors contribute predominantly to the neonatal jaundice, mostly physiological jaundice. Okay. So when it's come to the etiology, we know it. One is the physiological jaundice. So physical jaundice is due to physiological immaturity of the neonate. So it appears between 24 to 72 hours of age. Peaks to levels of 12 to 15 by 3 to 5 days of age. Then it falls gradually, normalized by 2 to 3 weeks. Okay. In preterm infants, peak levels can occur on day 3 to 7 and may rise over 50 milligram per deciliter. So when it's come to the physiological jaundice, is the peak levels are generally 12 to 15 milligram per deciliter by 3 to 5 days. Then it falls, then it shows falling. Okay. So this is, we can say, the physiological jaundice level. When the jaundice with our bilirubin increases above these levels generally, then we have to look for the other risk factors as well. So physiological jaundice is generally can be become exaggerated by the certain risk factors. Okay, these are the risk factors which lead to subsequent hyperbilirubinemia. Okay, or exaggerate the physiological jaundice in most of the neonates. So this can be immaturity of the lower gestational age, jaundice in the neonate in the first 24 hours, pre-discharge transcutaneous or total serum bilirubin close to the phototherapy threshold, phototherapy before discharge, parent or sibling requiring phototherapy or exchange, exclusive breastfeeding with suboptimal intake, and scalp hematoma. These risk factors can exaggerate the physiological jaundice. Yeah, that's why I'm mentioning here. Okay, these are the other hemolytic. Any hemolytic disease can also further exacerbate, and hemolytic disease itself is one of the etiology as well, or risk factor for the aggravation of the jaundice as well. So when it's come to the pathological jaundice, another cause is when we can consider pathologic when one or more of the following are present, like jaundice on day 1 of life, yellow palms and soles anytime. These are the clinical signs and some lab. The TRB increasing more than 0.2 milligram per deciliter per hour, or more than 5 milligram per deciliter 24 hours after 24 hours, and with the first 24 hours it is more than 0.3 milligram per deciliter per hour. When there are signs of acute bilirubin encephalopathy or kernicterus or direct bilirubin more than 1 milligram per deciliter at any age is pathological, and this is cholestasis. This needs to be this is associated with other signs like high colored urine. Clinical jaundice persists beyond 2 weeks. These are the signs of pathological where it gives us clues to the evaluate for the other causes. So when it's come to the etiology of the jaundice, so we know hemolytic diseases, whether ABO incompatibility, RBC membrane defects, or abnormal hemoglobin, or enzyme defects like G6PD. Okay. Others are hematoma, polycythemia, sepsis, large for gestation age of diabetic mothers, increased hepatic circulation due to the decreased breastfeeding, or in intestinal obstruction, decreased conjugation due to generally to the premature and others are hepatocyte enzyme disorders. Okay, predominantly we are discussing all these etiologic factors can cause independently jaundice, as well as they are the risk factors to exaggerate the physiological jaundice as well. These are the risk factors which can lead to the neurological sequelae or neurological complications. Okay, others the previous which we have seen are the risk factors for significant hyperbilirubinemia. These are the risk factors for the neurotoxicity. Okay, SOM in hemolytic disease, G6PD or the hemolysis disorder, gestational age less than 38 weeks, and it increases with the age of the degree of prematurity. Albumin less than 3 milligram per deciliter, and sepsis and significant clinical instability in previous 20%. Earlier, it was temperature instability, hypothermia, acidosis, and birth asphyxia. Now, they in 2022 they remodified it to the clinical significant instability phase 24 hours. So these are the risk factors for neurotoxicity. The previous one are risk factors for the hyperbilirubinemia or etiological factors or risk factors. So why we are concerned more about the management of the hyperbilirubinemia? Okay, even physiological, it is most common problem, and so it has complications which are severe. It can be bilirubin-induced neurological dysfunction. Others can be related to mortality as well. These are the major complications and what we wanted to prevent. So bilirubin-induced neurological dysfunction can be as acute bilirubin encephalopathy, mostly present in the neonatal period, or it can be connectors of chronic bilirubin encephalopathy, which presents after generally 1 year after the age. Okay, so bilirubin can lead to mortality independently when it is more than 30 milligram per deciliters or it's above the threshold levels in the serum bilirubin. So when it's come to acute biliary encephalopathy, when you look at the signs and symptoms of there will be decreased feeding, lethargy, abnormal tone. There can be hypotonia or hypertonia, high pitched cry, metropolis, and opisthotonous posture, setting sun sign, fevers, and seizures. These are the signs of acute biliary encephalopathy. This condition is generally reversible when we appropriately, when we manage promptly. Okay. So when we are not able to identify or when it undergoes unnotified or when we delay the management, it can lead to chronic sequelae, which is chronic biliary encephalopathy or connectors. So it is manifested by tetrad of one or any of the four. Okay. So abnormal motor control or movements and muscle tone. So commonly it is choreothetide CP. Okay. The second is auditory processing disturbance with or without hearing loss. Other components, oculomotor impairments, especially impairment of the upward vertical gaze and dysplasia of the enamel of deciduous teeth. Any one or more can be helps in the diagnosis of chronic bilirubin encephalopathy. So these are the major complications. So that's why the bilirubin should be managed, identified early, and managed even before the complications arise. Okay. So when it's come to the jaundice, when you see the outborn child, or then we have to thoroughly evaluate for the diagnosis to look for the etiological factor importantly, and what needs to be taken care of. So history is important. Onset of jaundice, the day of jaundice, which can alert us regarding the pathological causes. Stool color and urine color, high colored urine, pale stools can alert us regarding the cholestasis. Okay, presence of pruritus again alerts in presence of cholestasis. Detailed birth history need to be documented. Most of the time it is well known in case of inborn cases, but in case of outborn cases it should be asked regarding the then metallurgical, serological, especially in case of Rh negative previous pregnancies, whether maternal antibody is present or not, and blood grouping and typing. Previous family history of previous sibling neonatal jaundice, requirement of any phototherapy, extent transfusion, and maternal gestational diabetes mellitus is also important. So from history, we can get clues regarding the breastfeeding jaundice or breast milk jaundice. Okay, we have seen earlier the physiological jaundice and the causes of pathological jaundice. Breastfeeding jaundice is breastfeeding inadequate jaundice due to decreased breastfeed. So mostly seen in the first week of life. Okay, it's due to inadequate breastfeeding. Okay, maybe associated with the dehydration, associated with intestinal obstruction. It generally improves with feeding. Okay, when it's come to the breast milk jaundice, generally seen in the first week of after the first week of life, the 2 to 3 weeks of life. It's present in children with adequate breastfeeding and adequate weight gain, and it generally not harmful. It gradually improves. May take 3 to 4 weeks to improve. In very rare, in very few cases, it may take 4 to 6 weeks as well. So one way we can diagnose is you can stop the breastfeeding and you can do formula milk. Okay, but not necessary always unless the bilirubin is very high. So from history, we can get some clues regarding the condition, so it helps in the further management. So in examination, when it's come to the examination, visual inspection of the jaundice by Kramer scales. Okay. So all children need to be visually examined from 12 hours of their life, okay, till discharge. Okay. Presence of one or more presence of the following palar, petechiae, cephal hematoma, subgaleal bleed, extensive bruising, signs of dehydration need to be examined. And also we wait for anthropometry and system examination, look for any hepatosplenomegaly and look for any abnormal facies and look for the neurological sequelae in the examination as well, the tone and the movements of the child. In examination, you can see the modified Kramer scale for the visual examination. So these are the bilirubin levels in cephalocardal direction. Okay, so bilirubin gets deposited initially in the face first, followed by the chest, abdomen, and the palms and soles. So when it's come to the lab investigation, the first we can do is the transcutaneous bilirubin initially. Okay, when transcutaneous bilirubin levels are more than 50 milligram per deciliter or within the 3 milligram per deciliter of the phototherapy range, we have to measure the total serum bilirubin. Okay, in case of any hemolytic disease or in case of any bilirubin hyperbilirubinemia requiring phototherapy, we need to evaluate for the underlying cause as well. This can be complete blood picture, peripheral smear, reticulocyte count, or direct KIMS test or direct antiglobulin test, and G6 enzyme assays can be performed routinely, or it should be performed when there is increase in bilirubin or sudden increase in the bilirubin, or it doesn't even on intensive phototherapy. ABO blood grouping and typing, and liver function test in case of the prolonged jaundice or persistence of the jaundice beyond 2 to 3 weeks. When it's come to the management, so from the newborn period time, so let's look at some general principles when we have to follow in the inborn neonates, and what are the other specific phototherapy, external transmission. Okay. So all neonates should be examined visually from 12 hours of life and every 12 hours of thereafter. Okay. And transcutaneous bilirubin or TSB should be done in all neonates at 24 to 48 hours life or at least before discharge in neonates. Okay. Whenever the transcutaneous bilirubin more than 50 milligram per deciliter or within the 3 milligram deciliter of the phototherapy range, total serum bilirubin should be measured. There should be a risk stratification after the measurement of the total serum bilirubin or transcutaneous bilirubin according to the bilirubin nomogram or the latest phototherapy threshold nomograms. Okay, and according to the Documentation of the nomogram after the risk stratification, the follow-up time and plate should be informed to the parents. When bilirubin threshold is more than the phototherapy rate, these children should be started on phototherapy rather than discharge. Okay, these are the nomogram for the phototherapy. So American Academy of Pediatrics, bilirubin nomogram, or you can say the threshold for phototherapy. So even when we measure we have to measure bilirubin for all children for 24 to 48 hours of age, and we have to chart on the nomogram and see whether this child qualifies for the phototherapy or not, or how much is away from the phototherapy range. Okay. This is for phototherapy threshold with no hyperbilirubinemia neurotoxicity risk factors. So we have seen earlier neurotoxicity risk factors are isomin hemolytic disease or other hemolytic disease, gestational age less than 38 weeks, hypoalbuminemia, and sepsis or instability. Okay, so we have to chart on these phototherapy thresholds according to this is without risk factors, and next one is the with risk factors. So when it's compared to the earlier nomograms, the threshold for phototherapy have been increased. So this is depending on the expert opinion field studies from the last 10 years. However, the increase is only 1 milligram per deciliter for the upward scale and 1.5 milligram for the lower thresholds. These are the threshold for with risk factors. Okay. So we have to look at the bilirubin levels, look at the risk factors, and then chart according to the appropriate chart and see whether child falls into the phototherapy range or how much how away is from the phototherapy. So depending on this, we can decide on the discharge, and also we can also decide the time of follow-up as well. Okay, as we have seen the general principle, all units should be undergo TCB or transcutaneous or total serum bilirubin. Okay, and they should be it should be charted on the phototherapy threshold and see if the TSB at or above the phototherapy threshold, then start phototherapy. If not, then you can prepare for the discharge. But whether we have to see that if bilirubin is 0.1 to 2 milligram per deciliter within the range of phototherapy and child is less than 24, you have to delay the discharge, consider phototherapy. Okay. If age is more than 24 hours, consider delay the discharge or at least measure bilirubin within next day and start phototherapy. Okay. When bilirubin is 2 to 3 milligram per deciliter within the range of the phototherapy, you can discharge and repeat after 1 hour or 1 day. When it is 3 to 5 milligram per deciliter, regardless of the age of the discharge, you have to call back child in 2 days. Okay. When it is more than 5.5 and less than 7, if child is being discharged less than 72 hours, you have to call back after 2 days. If child is being discharged after 72 hours, you have to clinically judge and see. You can call in 2 to 3 days most of the times. Okay. If the is more than 7 milligram per deciliter away from the phototherapy threshold, then if call within 3 days, or see look at the if child is discharged after 7, like you are discharging after 1 week, 2 weeks, then you look at routinely call for other therapy rather than the bilirubin because it's less likely to persist beyond 2 weeks. So within 72 hours, you have to. So within 72 hours, you have to call within 2 to 3 days. Okay, when the threshold, when the bilirubin levels are away 5 to 7 milligram away from the threshold. So most of the neonates can be called within 2 to 3 days whenever there is when being discharged within 72 hours. Okay, but when bilirubin level is when bilirubin levels are within the 3 milligram deciliter of the phototherapy range, you have to call next day. Okay, so if child is not being discharged and started on phototherapy, then how to look for the phototherapy? So when the bilirubin levels is more than the thresholds for phototherapy, the unit should be started on phototherapy. It is Intensive phototherapy, what we follow is, so in intensive phototherapy is dependent only on the intensity and surface area of the child exposed surface area. Okay, so that's why it is important to look for the child should need to be exposed properly, and that is narrow spectrum LED blue light with irradiance of at least 30 microwatt per centimeter square per nanometer at a wavelength of 475 mm. Other wavelength can lead to the unnecessary heat. It can be intensive phototherapy. It can be quickly lower the total serum bilirubin and shorten the duration of treatment as well. And the children should be kept within the 30 centimeters of the source of light. And to increase the intensity, we should cover from all sides. Okay. So when the child is started on phototherapy, the total serum bilirubin should be measured within 12 hours, or you can say every 12 hours. And for all children who are undergoing phototherapy, need to be look for the hemolytic causes, like for the hemoglobin, CBP, to look for the anemia, blood grouping and typing, and if RH negative, need to for the DCT or KIMS test as well. G6 should be measured when there is no improvement even on phototherapy initially. So phototherapy should be discontinued when the bilirubin is at least 2 milligram per deciliter below the hour specific threshold at the time of the initiation. Okay. Longer period of phototherapy can be an option depending on the risk factors. Like rebound, we have to look for the risk factors for rebound hyperkalemia. The gestation is less than 38 weeks, age is less than 40 years at the start of the phototherapy, and hemolytic disease. Then you can prolong the phototherapy according to the clinical judgment. Okay. So we can discontinue when there is bilirubin less than 2 milligram per deciliter. So all children with phototherapy should be followed with total serum bilirubin every 12 hourly. And whenever there is less than 2 milligram per deciliter, we can follow 2 threshold levels, or even 1 threshold is also effective for the stopping of the phototherapy. So whenever there is no improvement, or there is a bilirubin threshold is above the phototherapy and just 2 milligram per deciliter below the exchange transfusion, then you have to escalate the care. Okay. So when TSB exceeds the escalation of care level, which is 2 milligram per deciliter below the phototherapy level, then look for the whether this unit or facility is appropriate for location for the exchange transfusion. If it is yes, you send all investigations for the hemolysis, like total and direct serum bilirubin, albumin, serum chemistry, and blood typing and grouping and typing. Notify blood bank, measure TSB at every 2 hours. When there is needs escalation of the measure every 2 hours, and start children on intensive phototherapy and IV plus oral hydration as well. You can consider IVIG therapy if the child is in case of immunohemolytic diseases and neonates with positive direct antiglobulin test or DCT. If there are any signs of acute bilirubin encephalopathy, the child needs to be undergo urgent exchange transfusion. Or latest TSB, we have to measure every 2 hours. Whenever there is, we are escalating the care, measure every 2 hours. When there is latest bilirubin above the exchange transfusion, should go urgent exchange transfusion. So once starting intensive phototherapy and hydration, and we are measuring serial 2 hours bilirubin, if the further subsequent bilirubins are below the threshold levels, you can return to the regular phototherapy. If not, you'll continue and look for the photo exchange transfusion. In case of the facility have there are no facilities for the exchange transfusion, consult the neonatologist or transfer to the facility where there is available. Okay, and during the transfer, you can start children on phototherapy and IV and oral hydration. So these are the nomograms or threshold for the exchange transfusion. This is the exchange transfusion threshold without any risk factors, neurotoxicity risk factors. Okay. And this compared to the 2004 American Academy guidelines, these have been increased 1 to 2 milligram, 1 in case of the upper threshold and 2 milligram per deciliter can have the lower threshold. This is again depending on the cross-sectional studies from the last 10 years. Generally after 4 years it will be remain constant most of the time. These are the exchange transmission threshold with risk factors. So what are the exchange transmission that was specifically follow? All children who requires escalation of care should be started intravenous hydration and intensive phototherapy. Neonatologist should be consulted in case of urgent transfer, or you can be transferred to the facility where available. TH should be measured every 2 hours, and consider intravenous immunoglobulin in case of isoimmune hemolytic disease and child has positive antiglobulin test or DCT positive. So we should notify the blood bank for the cross-match packed red blood cells and fresh frozen plasma with 40%, assuming 40% hematocrit. And there is another factor which can alert to start early for exchange transfusion is the bilirubin to albumin ratio. When you are awaiting for where you started child on escalation of care, awaiting for the exchange transfusion, when we got albumin or bilirubin levels, we have to look for then the albumin to bilirubin ratio is more than 8 in children more than 38 weeks gestation. With all these children should be started on exchange transfusion. So for children with more than 38 weeks of gestation with neurotoxic risk factor, if it is more than 8, we need to start when there are no toxic risk factors. And when there is one hyperbilirubinemia neurotoxic risk factors, then if it is more than 7.2, you have to consider. Similarly, for the 35 to 37 weeks gestation, this is without risk factors and this is with risk factors. This is bilirubin to albumin ratio. So other than the exchange transfusion nomograms or threshold, you can also look for the bilirubin to albumin ratio. Another thing is, even the bilirubin is below the threshold, but child has signs of acute bilirubin encephalopathy. So this requires urgent exchange transfusions. IVIG is another mode of the pharmacological therapy available in case of only isoimmune hemolytic diseases. So it is manufactured from the pooled plasma from around healthy donors. So all preparations contain high concentration of the IgG. Minor contaminants can be there with trace amounts of IgA, cytokines, and soluble cell surface human leukocytes. So mechanism of action is it acts by blocking the FC receptors on the macrophages. So reduces the breakdown of antibody coated to the RBCs. So reduce the breakdown of RBCs and enhance clearance of maternal antibodies. You can see the mechanism here. So So immunoglobulin binds to the FC receptors present on the RBC and prevents hemolysis. Okay, so these are the maternal antibodies that bind to the RBCs and cause hemolysis. So, but when we give IVIG, it blocks the receptors and prevents the hemolysis and further hyperbilirubinemia. Where IVIG is not without any adverse events, it can cause adverse events like hypersensitivity reaction, and there can be some viral reaction, but nowadays it is very safe. The infection is divided up the infectious agent. Earlier there was transfer of infections through IVIG, but nowadays we see less. However, the anaphylactic reactions can be seen, so we need to be vigilant during the case of phototherapies, IVIG in case of the bilirubin. So this we have seen the overall the bilirubin metabolism, the risk factors for the significant hyperbilirubinemia, risk factors for the neurotoxicity, and overall management, general principles in the neonatal units, and then following when phototherapy need to be initiated, exit transmission. You can see the algorithmic approach as we have seen whenever there's neonatal jaundice. Yes, when there is, you have to look for the total bilirubin. So first initially we can screening, we can use transcutaneous bilirubin, but when we know that when transcutaneous bilirubin more than 15 or less than within the 3 milligram per deciliter of the phototherapy, we need to measure the serum bilirubin as well. So we have to look for this physiological jaundice. Okay, it can be continued observation and repeat total bilirubin if there is worsening or increase hyperbilirubinemia. Okay. The pathological jaundice measure the direct bilirubinemia, or you can look for the signs of the when like pale stools or high colored urine. Then it indicates direct hyperbilirubinemia or neonatal cholestasis. These children need to be evaluated further and treated according to the etiology. In case of indirect hyperbilirubinemia, so hemolytic disease should be evaluated first. Okay, so we have the CBP blood grouping typing. If there is direct antiglobulin test or KIMS positive, then look for the isoimmunogen disorders and treat them accordingly. In case of KIMS negative and there is hemoglobin is low or normal, look for the reticulocyte count. If reticulocyte count is normal, then look for the extravascular blood, but like increase at improper circulation, metabolic errors, okay, and drugs. When it is high, look for the RBC morphology. If abnormal RBC morphology, it can be diagnostic if there are spirocytes, electrocytes, and or it can be hemoglobinopathies, enzyme dysfunction. It can be non-specific abnormality. In case of KIMS negative and high hematocrit, look for the polycythemia and maternal fetal transmission and other causes. So this is overall picture. Just to here we have to be vigilant in cases of the direct hyperbilirubinemia. We need to be ruled out the cholestasis here. Rest we have to look for the hemolytic causes and work up further during the management while while child is being managed for the phototherapy or external transmission. You can further evaluate for the etiological causes. We can look at the few cases here. This is a 6-day child presented to OPD on day 6 of life with yellowish discoloration of eyes and skin associated with pigmented stools, accepting feeds while gaining weight. So on examination, child is normal with normal vitals. Anthropometry weight is adequate compared to the birth weight in 5 days of life. There are jaundice till lower limbs, no pallor, and systemic examination otherwise normal. So we have screened with a TCB that is 10 to 10.2 milligram per deciliters. So clinically, there are no the child is active, accepting feeds well, okay, and gaining weight normally, and TCB is within is 10.2 milligram deciliter. This looks more like the physiological jaundice. So here you can so child is 6 days of life. Day 6 of life, and bilirubin is 10. The child has no risk factors. So 37 weeks, child is late preterm. So 36 weeks. You can see the chart the bilirubin here. Day 6, it will be around here. So less than the phototherapy range. Okay, so 5 to 6 milligram deciliter less than the phototherapy range. So child can be reassured, parents can be reassured regarding the physiological jaundice, can advise adequate breastfeeding and can be discharged. So physiological hyperbilirubinemia, we already have looked at in the etiological factors. So mean PTSB 48 to 76 milligram can rise maximum up to 10, 12 to 50 milligram per deciliters and start declining by 5 days of life. From neonates, it can persist to 2 to 3 weeks as well. Only few 10% of it require the phototherapy. In premature infants, it can be peaked by the 10 to 12 days, and thereby it takes normalized by the 3 to 4 weeks. So when it's come to the physical hyperbilirubinemia in different gestational age group, okay. So normalization is faster in case of full-term neonate infants and slower in case of the premature infants, okay. The mainly full-term infants only 10% require phototherapy, where it's come to the near-term or preterm require 25% require the phototherapy. So in preterm and near term, that if the peaks later and the peak value can be higher than the term infants and decline is slower, and more children will require, more neonates will require phototherapy. So physiological hyperbilirubinemia causes we have seen already. One is there is increased bilirubin production, okay, due to inefficient hepatic, and one because the RBC half-life is lower in case of the neonates is 70 to 90 days. The factor 2 is the inefficient hepatic excretion of bilirubin due to the immaturity of the hepatic enzymes, okay. And more bilirubin monoglucuronate than so inefficient hepatic excretion of bilirubin. One is decreased enzyme activity, other two is increased glucuronates, mono and diglucuronates in case of the bile, which can lead to subsequently increased enterohepatic circulation. Okay. Next is the increased enterohepatic circulation. Here, at the same time, increased beta glucose activity in newborns, and because glutathione activity in even if the presence of bacteria can also lead to increased hydrolysis of mono and diglucuronates, increased intestinal reabsorption. So another risk factor is inadequate intestinal microbiota. So low bacterial degradation of the bilirubin, increase reabsorption in the enterohepatic circulation. These are the factors which are responsible for the physiological hyperbilirubinemia. So decreased RBC half-life, inefficient hepatic excretion, increased enterohepatic circulation, and decreased intestinal flora. So it's 5-day child, male. Okay, so born out of normal vaginal delivery with birth weight of 3.1 kg, presented to OPD with yellowish discoloration of eyes, skin, and excessive cry for last 2 days. Associated pigmented stools. Otherwise, child is irritable with vitals are within normal range, or there is, and look at the total weights. So this is 2.5 gram, 5/8. So this here child has inadequate feeding and excessive weight loss, more than 20% here. So it can be due to the other examination. We can see there is skin pitch delay, jaundice till lower limbs, pallor, and maternal examination. There is a risk factor for inverted nipple as well. So the TCB is 19.8 milligrams. So what is next? We have to measure the total serum bilirubin. So when more than TCB is more than 50 milligram per deciliter, you have to measure the total serum bilirubin as well. So the diagnosis can be there are weight loss, significant weight loss, and feeding issues are there. So it can be breastfeeding jaundice. So here we have to again look for the 5 days, day 5 of age. So the bilirubin is within, so phototherapy threshold is 40 weeks for 5 days of life. Threshold is 21 milligram per deciliter. Here the child has 19.8. So this child is just below the phototherapy threshold. So we need to correct the risk factors here, the feeding issues, and you can take care of the hydration if there is by the IV or by adequate breastfeeding or by the other methods. So And while monitor the child, establish the risk factors like feeding issues and look for the bilirubin levels. Whenever it exceeds the threshold, we can start on phototherapies. So this is another child, 35 days of old, male child born by normal vaginal delivery, birth weight of 3.4 kg, presented to OPD with yellowish discoloration eyes and skin, associated with cough and cold for 2 days, not associated with any respiratory distress, associated with any pigmented stools. Okay. Otherwise, child is vitals are normal. With anthropometry, is weight gain is normal. There are ictus present, no pallor. System examination normal. Other risk factors are the child is 35 days. Okay. On examination, that bilirubin. So because the child is more than 4 weeks old, and we have to measure in all children, look for the pathological jaundice more than 2 weeks of the duration. Okay. So here the total serum bilirubin is 6.8 milligram deciliter and conjugated is 0.6 milligram deciliters. You can say the direct bilirubin is. So here it is predominantly unconjugated hyperbilirubinemia and child is 35 days old. So what can be the causes? So one can be in the very few cases, there can be breast milk jaundice can be seen up to 4 to 6 weeks. But here it is a predominantly unconjugated bilirubin. Other etiological possibilities can be so any hemolytic disease, which is milder, or it can be the hepatic enzyme deficiencies causes. Okay. These are the though in neonatal, when we look at the guidelines, most of the neonatal phototherapy, we look at hemolytic and physiological maturity. Let's have a look at the bilirubin disorders of bilirubin metabolism due to the enzyme deficiencies. Okay. These are the unconjugated hyperbilirubinemia disorders due to hepatic enzyme insufficiencies. Gilbert syndrome, Ligdon-Najjar syndrome, type 1 and type 2. So the prevalence of CNJ1 and 2 are very rare. Gilbert is 3% present in the population, which is you can say one of the common conditions, unconjugated hyperbilirubinemia. So it can be autosomal recessive or dominant. And type 1 is autosomal recessive, type 2 is autosomal recessive, rarely dominant. So all three are due to the UDP glucuronide transferase 1A1 enzyme mutation. So the enzyme is the normal and the presentation is different depending on the mutation part. Okay. In Gilbert, there is also defect in the uptake of the microsomes. Okay. There is abnormal uptake as well as the enzyme deficiency as well. So when it's come to the glucuronidation and uptake, both are defective in Gilbert, and only glucuronidation are defective in the CNG. So when it's come to the enzyme levels, it is 5 to 53% of the controls. It is severely reduced in the type 1 and 2 to 3% of the controls in case of type 2. So the important thing here we have to look for is the bilirubin levels. Okay. Generally 0.8 to 4.3 milligram in case of the Gilbert, whereas 15 to 45 in case of the type 1 and 8 to 25 in case of the type 2. So here it can increase during the acute illnesses like any URI and may come down later. Okay. However, we have to identify this 1 and 2, where few children can also require phototherapy and exchange transmission as well. These children are at significant risk of the bilirubin-induced neurological dysfunction or kernicterus. So when it's come to serum bilirubin composition, so unconjugated are present 98% in case of the Gilbert. So 100% in case of the type 1, 99%. When it is the diglucuronidase is 1.1 is nil, di and nil in case of the di and monoglucuronides are absent in case of the type 1, whereas mono is present 0.6 in case of the type 2 and di is absent. So here monobubbles are predominant up to 1.1%. When it's come to the diglucuronides is up to, this is in the bilirubin and this is in the bile. Okay, when it's come to the bile, diglucuronides are present in 60% and monobubbles in 30% case of Gilbert, whereas they are absent, and it is medium in case of the type 2. So these children type 1 are at high risk for kernicterus and occasionally can cause, these are benign and they can persist lifelong, but doesn't cause any risk factor for the neurological dysfunction, but may have associated with UGT1A1 enzyme isoforms can also, is also involved in the xenobiotics and toxin transformation. It's associated hypersensitivity, some drug hypersensitivities can also present in this children. So another bilirubin is excreted into the canaliculi without the MRP2 receptor, and mutation of this receptor can lead to the Dubin-Johnson syndrome, which is present in the apical canalicular membrane. At the same time, that there can be glutathione S transfer, which helps in cytoplasmic transfer of the conjugated bilirubin in hepatic cytoplasm. So mutation of these genes can lead to the conjugated hyperbilirubinemia. Okay, these children have high colored urine and other symptoms. So here the bilirubin levels can be 2 to 7. These are predominantly conjugated bilirubin, not the unconjugated bilirubin. Okay, it will be 1.5 to 6 in case of the Johnson. Okay, here the diagnosis is mainly by urinary carpoporphyrin excretions. So it is 1 and 3, 2.5 to 5 times the increase, which is normal in the Johnson. You can differentiate both and depend on the isomer 1 composition. Both. There is another is brown black liver in case of histopathology in case of rotor, and there is Dubin Johnson. Brown black liver is present in Dubin Johnson, where it is absent in case of rotor. So predominantly both are benign conditions. Occasional abdominal symptoms may be seen in Dubin Johnson. So this we have seen kept here for the purpose of looking at the bilirubin metabolism. However, these are the rare disorders when it's come to the neonatal hyperbilirubinemia physiological jaundice. So today's take-home message is the jaundice is the most common medical condition in the newborn, and all neonates should be visually examined every 12 hours from 12 hours of life, and all neonates should undergo TC, the transcutaneous or total bilirubin at 24 to 48 hours of age, and these children should be early differentiated from the cholestasis, and all children who require phototherapy should be worked off of the hemolytic causes. As we already shown, the all neonates should be screened at the time of discharge and look for the bilirubin levels and chart. You can measure the phototherapy range, and you can call according to the different the variation according to the how far away from the phototherapy range. If phototherapy range is where the bilirubin levels is very close to the phototherapy range, you can delay the discharge. If it is 3 to 5 milligram, let's say, you can call back after 2 days. If it is more than, you can call back after 3 days. Thank you. So we are closing the session now.